Welcome to Newcastle Family History Society podcasts. The Newcastle Family History Society, located on Awabakal land in Newcastle, New South Wales, Australia, provides support for those interested in family history. This is part 2 of our series, How It Was, the podcast that brings history to life through the lens of personal experience. Dr. Pamela Harrison OAM will take us back to a time when medical innovation was hands-on, resourceful, and sometimes a little peculiar. In this episode, Pam will guide us through the fascinating world of 1950s pathology, a time when glass syringe needles were sharpened by hand, pregnancy tests involved amphibians, and the dawn of automation was just a gramophone motor away. Stay tuned as we explore how these humble beginnings shaped the sophisticated medical practices of today.
When aged 16, I walked into the pathology laboratory at the Newcastle Mater Misericordiae Hospital, we called the Mater, in February 1954. It was the start of a journey of over 40 years, during which I witnessed remarkable changes and advancements in pathology and medicine. The pathology department at the Mater was opened in 1937, and at that time occupied 2 rooms above the mortuary. It was equipped by Dr. Samuel Gardner, a surgeon and Newcastle legend at the time, and a great supporter of the Mater and its nursing staff. It was staffed by Sister Constance Casey, a religious sister of mercy, under the direction of Dr. Ethel Byrne, honorary consultant pathologist. Frank Paul was employed as Sister Casey's assistant in 1938. On his return from RAAF war service in the Pacific, Frank replaced Sister Casey as laboratory manager, and he was joined by Rita Paff, later Brennan, whom he trained. Rita used to travel by tram to take tissue samples to Dr. Byrne's laboratory in Tyrrell Street for processing and diagnosis. The appointment in 1951 of Reginald Prosser, a very experienced histopathology technician, meant the processing could be done at the Mater. In 1952, a new pathology department was opened on the first floor of the new wing on the northern end of the hospital above the laundry, and another trainee, John Harris, was added to the staff. In 1954, first full-time pathologist, Dr. Kevin White, was appointed. He immediately increased the capabilities of the department by employing a science graduate, Francis Ingram, later Lambert, as biochemist, and added another trainee, myself, making a technical staff of 6. When Rita Brennan retired as laboratory manager in 1987, the staff numbered 64. A pathology technician was one of the few occupations in which women received equal pay, except in Commonwealth repatriation hospitals, where the female wage was significantly less than for males. Only a few women were employed, and staff vacancy advertisements often appeared in the newspaper columns headed Men and Boys. Training at that time was rather like an apprenticeship, with low wages and 5 years of night classes, consisting of 3 years at the Technical College at Tyers Hill to obtain the laboratory assistant certificate, and then 2 years study for the certificate in medical technology examinations, which were held in Sydney. This certificate covered the subjects relevant to the work we were performing: haematology, biochemistry, histopathology, which is preparation of tissue removed from the body to diagnose cancers, etc., and bacteriology, which identified the bacteria causing infections and the appropriate antibiotics to treat them. The classes were held at the Royal Newcastle Hospital Pathology Department. One of the highlights I remember was the night in October 1957 when the first satellite to circle the world, the Russian Sputnik, passed overhead, and we could see it clearly from the roof of the old outpatients building. The junior trainee's main job was to clean the used laboratory equipment. It was an era of recycling with no throwaway plastic technology. All the equipment was made of glass, which had to be washed and reused. Some of it had to be sterilised in an autoclave before washing because it had been used to grow bacteria, and was sterilised again before being reused. All the cleaning was done in the wash-up room, which also served as the staff tea and lunch room. The heat generated by the sterilising equipment made it extremely hot in summer, and the smells emitted by some of the items for washing added to the discomfort. There were no health and safety regulations in those days. Nevertheless, the staff enjoyed their tea and lunch breaks, and there was no cross-contamination from the bacteria. Syringes used for collecting blood were made of glass, and after use were washed and the needles inspected with a special magnifying glass. If the needles were blunt or barbed, they were sharpened on a sharpening stone before being placed in a glass tube designed to protect the needle point. Each syringe, with the plunger separated from the barrel, together with a needle in its container, was wrapped in a linen cloth, autoclaved, and then dried in a hot air oven. The syringes were then ready to be used again. There were no cannulas to insert into a patient's vein like the plastic ones in use today. If a patient needed to be given fluids or blood through a vein, that is intravenously, a metal needle was used. Sometimes a minor surgical procedure was required to insert the large metal needle into a vein. The needles, of course, were reused after being sharpened and sterilised. By the end of the 1950s, plastic was beginning to replace glassware in the laboratory, and the invention of heat-resistant plastic resulted in the use of sterile plastic disposable syringes with disposable needles, which also ensured the needle was always sharp, as well as sterile. All the blood tests were done individually by hand, using reagents made in the laboratory from bottles of chemicals, acids and dyes, as there were no commercially available tests. The culture medium for growing bacteria required sheep and ox blood, which were obtained from the nearby abattoir at Waratah, now replaced by the suburb of Warrabrook. The tests for glandular fever, infectious mononucleosis, required fresh sheep blood, so the test had to be done the following day, as the blood had to be collected early in the morning to coincide with the time the sheep were slaughtered. Frank would go to the abattoir on his push bike, often scoring a lamb's fry on his visits. The test also required ox blood and an emulsion of guinea pig kidney, which were also prepared in the laboratory. The test was then set up using the patient's blood and these reagents and took hours to get a result. The test was important as the virus affects the appearance of the white cells in the blood and could be mistaken for leukemia. The commercially produced test, Monospot, introduced in the late 1960s, gives a result in less than a minute. Performing a full blood count required time and skill and consisted of the measurement of the blood hemoglobin, packed red cell volume and white blood cells with the examination of a blood film. The hemoglobin carries oxygen to muscles and tissues and gives red blood cells their colour. A reduced amount of hemoglobin is a sign of anemia. It was calculated by a test measuring the colour in an instrument called a colorimeter, and the result read off a graph. White cell numbers were counted using a glass counting chamber and a microscope, and the result calculated manually. There were no digital calculators in those days. I borrowed my father's slide rule to do the calculations, and one was later purchased for the laboratory. Red cell and platelet counts required similar techniques, but were only done on request, as they took longer to perform and were less accurate. The packed cell volume was a simple test using a centrifuge, but took half an hour for a result. A blood film was made by carefully smearing a spot of blood on a glass slide, which was then stained with dyes, taking about 30 minutes. The slide was then examined under the microscope to identify the individual white cell types, and 100 counted to obtain their percentage. The appearance of the red cells was examined for clues for abnormalities, such as iron or vitamin B12 deficiency, and the numbers of platelets assessed as normal, low, or increased. Thus, a full blood count could take up to an hour to perform. Of course, urgent specimens would have priority, and a haemoglobin could be done in minutes, provided the laundry below us was not using its spin dryer, as its vibrations would cause the colorimeter needle to swing wildly, making it impossible to use. My father came to the rescue again when Dr. White showed me a photograph of a machine used for mixing blood in test tubes. Blood had to be mixed thoroughly by tilting the tube back and forth by hand before any test could be performed, but this device mixed it for you. It consisted of a flat, rounded disc which rotated at an angle, and the test tubes were attached by clips to the upper surface. My father was an electrician, and his hobby was building and repairing wirelesses and gramophones. He donated a motor and a gramophone turntable, which rotated at the newly introduced LP record speed of 33 1/3 revs per minute. The old 78 would have been far too fast. The hospital carpenter built a box to conceal the motor and hold the turntable at the required angle, with clips for the test tubes. Automation had arrived. Pregnancy tests involved using laboratory animals and were only performed for difficult obstetric cases, not routinely as they are today. Female mice had been used in the past, but the test took 4 days to perform, and the mice had to be euthanized to examine their ovaries to get a result. When I was taught to do a pregnancy test in 1955, the mice had been replaced by Queensland male sugarcane toads, which gave quicker results, and the toads were recyclable. They were sent from Brisbane by train and collected from Waratah Station by a staff member. They were housed in the animal house, a room above the laboratory, and placed in a cage on a hessian sack and hosed at least daily to maintain a moist environment. When a pregnancy test was ordered, a toad was placed in a small cage and brought to the laboratory, and a sample of the woman's urine was injected under the loose folds of skin on the toad's back. The handler had to take care to avoid touching the poison glands on each shoulder behind its eardrums. If the woman was 6 weeks or more pregnant, her urine contained enough HCG hormone to stimulate the toad to produce sperm. These would pass into its cloaca. The cloaca is assessed through an opening in the rear of the toad. It holds and allows the passage of urine, digestive waste products, and reproductive agents. After a set time, a sample was extracted from the cloaca using a glass pipette made by the staff and examined under the microscope. The presence of sperm confirmed the woman was pregnant, and the toad could be reused after about 7 days. Soon after the appointment of the biochemist, a flame photometer was purchased which could measure sodium and potassium, and a meter which could measure the pH of the blood. This meant that these components could now be measured in blood collected by Dr. White from the patients on intravenous fluids and he could advise treatment based on the laboratory results, which previously were not available. Frank Paul would make up the normal saline and 5% glucose solutions for the intravenous drips, sterilising them in the autoclave before taking the bottles to the ward. Now all intravenous fluids are imported, and currently there is a shortage, causing concern that it may jeopardise patient care. I suppose the Therapeutic Drug Administration would be shocked at any suggestion to return to how it was in the 1950s. Blood for transfusion came from the Royal Newcastle Hospital and District Blood Transfusion Service. The donor's blood was collected into a large glass bottle, which was rotated by hand to mix the blood with the anticoagulant, which stopped it clotting. However, sometimes clots were formed, so every time blood was needed for a patient, it was poured through a sterile metal filter into another bottle, known as the giving set, to remove any clots. This was done following strict sterile procedure in which all path staff were indoctrinated. The doctor would insert a long sterile tube through a hole in the lid of the giving set for an airway, and the latex tubing was attached to a short glass tube which also passed through the lid. The bottle could then be hung upside down, and after running blood through the tubing to remove air bubbles, it was attached to the needle in the patient's vein. Later, specially designed bottles were used, so no transfer was needed, and a mechanical agitator mixed the blood during donation to prevent clots forming. Now all this has been replaced by plastic technology, which is simpler, safer, and more versatile. The local blood transfusion service is no longer attached to a hospital. In 1995, it was transferred to the Red Cross and is a branch of the Australian Red Cross Lifeblood. All the biochemistry tests, such as kidney and liver function tests, were done individually by hand, and most took hours to get a result. Some involved handling cancer-causing drugs, such as benzodine, and poisonous chemicals, such as sodium cyanide and mercury. The bacteriology laboratory grew and identified bacteria from urines and wounds, etc., and tested them against antibiotics. At that time, there were only 5 antibiotics in use: penicillin, aureomycin, tetracycline, chloramphenicol, and streptomycin. There were no clinical immunology or genetic laboratories. Those sciences were only just beginning, and they developed at the Mater in the 1960s and 1970s. I left the Mater in 1958 after obtaining the Certificate of Medical Technology, and by the time I returned as haematologist in 1976, pathology and medicine were in the midst of change. Laboratory items mentioned in this podcast can be seen in the Pathology Museum I set up in 1997, celebrating 60 years of pathology at the Mater. The current cabinets were donated through the Heritage Committee, Calvary Mater, Newcastle, in 2011 and can be viewed in the corridor on level 3 at the Mater.
And that brings us to the end of this fascinating journey through the world of pathology in the mid-20th century. From washing glass syringes to the ingenious use of gramophone motors and even toads as pregnancy testers, the medical advancements witnessed during Dr. Pam Harrison's remarkable career reminds us just how far we've come in a relatively short time. Join us next time as Pam examines the changes and advancements in medicine that she witnessed from the 1950s to the 1990s. You've been listening to Newcastle Family History Society podcasts.